Hello, welcome to Hill and Ponton's video blog. I'm attorney Allison Reddick. Today we're doing a new series with a very special guest, Dr. Vonetes, a compensation and pension examiner, also known as C&P Examiner. Could you tell us a little about yourself, please?
Hi, welcome, and thanks for having me. I'm Dr. Alfred Vonetes. I'm a licensed psychologist with a practice in the Orlando area. A large part of our practice deals with veterans and compensation and pension evaluations. For the last 7 years, that's been my personal focus is compensation and pension evaluations with veterans.
So you conduct PTSD compensation and pension examinations as well as mental disorders examinations, correct?
Yes, ma'am. PTSD is definitely a large part of the claims, but certainly there are many other mental health claims that veterans put in for as well.
So in future videos, we will go through the different types, but today we're doing a general overview, walking through a mental health C&P exam, how an attorney sees it versus how you, the doctor, sees it. And we'll start with the basics. How would you say what a C&P examination is?
I would say a C&P exam is one, it's an informative thing, I guess you could say, and it's an informative meeting where it's not therapy where we're going through solving these issues, but realistically to look at it, it's a clinical interview of where we're getting as much information about a claimant as possible. And I also, because I usually only get about 40 minutes to an hour with somebody, I really try to explain to them and their significant others, family members, if they're present, about the whys to the stuff, why certain things might be happening. But another good thing about these exams is it does help veterans get compensation to pay for bills and finances that they're not able to work and provide for themselves like they used to be able to.
So basically what a C&P examination is when a veteran applies for compensation benefits. In order to get benefits, they have to prove that they have a current condition. In this situation, it would be a mental condition. They have to have some kind of stressor or incident in service. They also have to have a nexus, which shows the connection between the current condition and the stressor in service. So that is where you come in. You are the one who provides the nexus. And so when a veteran has a conceded stressor or a verified stressor, as well as potentially a current condition, you come in to either do an examination to provide a diagnosis, as well as provide your opinion on whether that diagnosis is connected to what happened in service. So,
Right.
mhm.
And then one step further is the level of impairment, how that person is functioning socially and occupationally.
So how do you prepare for a C&P examination?
So the main thing is the records. Having a C file, an electronic C file of the claimant's record is extremely beneficial. That gives me the DD-214. I'm able to see a claimant, the time they spent in the service, what branch of the service they were in, areas where they might have been deployed to, their MOS, also any badges, medals, honors they achieved in the service. All that stuff kind of helps to corroborate, the case, if you will.
So do they send you a paper file of that? Is it electronic? They send you the claims file? Do they send you any other materials?
I get electronically, I get the claims file, which is the records, which I only have access to those until the report is digitally sent off. And then because of HIPAA, I have no records. But I'm also sent a packet, which also has a hard copy of the DBQ and some very basic information about the claimant. Nothing that would be in violation of HIPAA. But they do send a hard copy of every single DBQ as well.
So the DBQ is the disability benefits questionnaire, and that kind of lays out the diagnosis you provide, their level of social and occupational impairment, symptoms, stressor, etc. Is that what you base your interview off of, and then you kind of fill it out afterwards, or do you fill it out as you're interviewing the client?
So, yes, I definitely base the entire interview on the DBQ, which outlines specifically what the VA is looking for in terms of not just diagnoses, but whether they conceded certain things or things in the records they want me to review. I will definitely base the entire exam on that. So I do the DBQ with them. I fill it out with them right while they're there. But it's important to know that when I'm doing this with them, I have them sit to the side, not in front of the screen where there's a barrier between me and them, because I like to see them. And as I'm typing, I will typically maintain eye contact with them fairly frequently. Unless, I mean, sometimes I'll even review the records while they are there. So, but the majority of the time I maintain the eye contact, but I fill out the DBQ while they are there. Yes.
Going off of maintaining eye contact, that's because you're also conducting a mental status examination. You're looking at their behaviors, their responses, whether they maintain eye contact. And that kind of also is something that veterans should know. That's something that you're assessing as well, and not to be uncomfortable
A hundred
with
percent.
that.
I mean, if I see something in the records that's incongruous, that even looks like malingering, I'll walk outside because I know what they look like, but they might not know me. I want to see how they're walking in. Are you skipping into the place and then now you're limping? I want to see how you're interacting with our staff. And a lot of times they don't know it's me, but I'll know it's them because of things they're wearing, ways that there's a lot of different things to profile. But I try to get absolutely as much information as I can, who they're with, how they're interacting with those people, other people that they might influence in the lobby. That I try to get any piece of information I can that will go into the behavioral observations.
You mentioned malingering. Now, as a attorney who represents veterans, in my opinion, I see so many veterans. Of course, there's going to be that 1% of people faking it, which is what malingering means. And I see a lot of C&P examiners that will say a veteran's malingering when they have these extravagant stressors. In your opinion, what percentage do you see of actual malingering veterans?
It's really small. Most of these people's claims are legit. Most of their symptoms are very legitimate. And every once in a while, I'll get somebody who tries to claim PTSD because they put their elbow in a fryer on a Navy ship or something like that. But most of these claims, I would say it's 1%, maybe even less than that. I'd say almost 100, 99 of 100 of them are very real claims.
Going back to the DBQ and the questions that you ask, is there anything off limits or that you're not allowed to ask about?
No, we can pretty much ask anything, especially if I feel it's clinically relevant. And many times the clinical relevance seems like it's hurting them, but it may actually be helping. So that's why, it's important to be an open and as honest in reporting this stuff. Because just to give you an example, a lot of people don't want to talk about behavioral problems they might have had. But, if I have a lady who, you went your whole into your 20s, never had alcohol problems, never had any behavioral problems, but now after this military sexual trauma, getting Article 15s for drinking, being disrespectful to authority figures, stuff that never existed before, sometimes those can be used as markers to actually help corroborate a claim.
And I know a lot of veterans are nervous about discussing alcohol or illegal drug use because they're afraid that you're going to turn them in or they're going to get arrested. How important is it for them to be honest about such issues?
Yeah, and that's a good question. In the way I pose that question to them, and especially with the drugs and alcohol, like, do you ever use drugs or alcohol where you think it's a problem? And that's a big thing because do you use drugs and alcohol? Sure. But do you think it's a problem? And I'll have some say, well, no, but my wife does. Or I'll say, well, what's a problem? What does a problem with alcohol look like? And then, if they say stuff like, well, I did get into a fight and got arrested, or I lost my job, or, things like that. But we'll also talk about legal stuff too. The legal problems and the substance abuse are, kind of one after another on the DBQ. If it's an initial, I'll go through their whole life on that stuff. If it's a review evaluation, for example, if the person is already connected for a service-connected mental health issue, I'll ask them how things were since their last C&P exam, which is usually 4 to 6 years, unless they either did a reevaluation or going for increase in benefits.
So, the way the VA rates mental health, regardless of what your diagnosis is, they rate it all under the same criteria. What is your take on that?
I find that to be very accurate, and I'll usually tell veterans like the VA is not concerned with labels. They're not into schizophrenia, bipolar, depression,
Mhm.
ADHD. They're focusing on level of impairment. How is this individual going to perform in a social or an occupational environment? If he's surrounded by a lot of people, is he going to be very edgy and maybe snap and hit somebody? Is this somebody who might dissociate on the job? Is this somebody who's hallucinating and taking medications for that now we don't want them operating a forklift, those kinds of things. So yeah, I would say that's a big piece.
I would agree with that as well because the way that it's rated, a lot of the symptoms are similar depending on the diagnosis. However, what's important is the actual diagnosis. And that is what leads to them being service connected. So I'll have a lot of situations where the veteran will have a stressor and the examiner will say they don't have PTSD, they have unspecified anxiety disorder, or they have unspecified stressor disorder.
Yeah.
Is there confusion in what they're supposed to be looking for, and does that negatively affect the veteran's ability to get service connected?
So let me say this about the stressors and if they meet criteria. So post traumatic stress, a lot like autism, is on a spectrum.
Mhm.
And what's traumatic to one person in terms of symptoms, it might not pop on somebody else's radar. Like some people could see a cat get ran over and it totally traumatizes them, where somebody else could see a whole family get mowed down and they're still able to work.
Mhm.
So I have seen cases where they're not meeting all the criteria, but what I'll tell the veterans is I am seeing you in a snapshot of time. So a lot of this stuff roller coasters.
Mhm.
And a lot of times when people retire, the symptoms come back because they'll dive into their work to mentally outrun this stuff. So I have seen where symptoms can fluctuate, but I'm with you where I have also seen where they have anxiety disorder, NOS, and this is clearly PTSD. This
Mhm.
person's having nightmares, flashbacks, detachment from people, can't work, anger, sleep issues. I mean, so I have seen some where, yeah, does it get you thinking like maybe they're trying to avoid the PTSD label? I have a lot of people ask me about the PTSD label, especially pilots and people that want to carry guns.
Mhm.
Is this going to affect my ability to do those things? In most cases where you look at it and you think this is PTSD, it usually is. It usually is. And I do find that usually the diagnoses that they're given are on the under to make it look
Yes.
not too bad.
Yeah,
It's
I'll
like
see a lot where it's major depressive disorder, but major depressive disorder is usually a secondary condition or within the PTSD
100%.
diagnosis.
I'll always tell the veterans the path from anxiety to depression comes across the bridge of avoidance, because a lot of these people had active lives,
Mhm.
and I'll say to them, maybe you used to like to go to ball games or concerts or shopping at the mall. Now it's not worth dealing with that anymore. That is too much. So you start avoiding, and you're not leaving your city. You're not leaving your house. Before you know it, it's like to work and back into a room all day. And when that happens, that starts our cycle into depression. So a lot of times, I'll have a veteran come in. They'll be, well, they diagnosed me with insomnia and anxiety and depression. And I'll tell them it's PTSD that's driving the whole train. These other
Yes.
things are, even the alcohol, that's just all coping strategy.
Mhm.
So I do feel like a lot of those comorbid diagnoses, they're just a result of the post-traumatic stress. And like I'll tell the veterans, if we went back in time and took away all these in-service experiences, most of this stuff, including the mood piece, would go away. So
Absolutely.
that really kind of lets you, makes it a little more clear of what's really the etiology of all the symptoms that they're experiencing.
So, when you have the DBQ and you're going through it with the veteran, what is the style of interview that you use? Are you asking the veteran if they're suffering from specific symptoms, or are you more of just having them discuss the symptoms that they feel they struggle with?
Yeah, that's an interesting one because, it depends on the person sitting across from
Mm,
me. I guess some people, they want to talk and they want to, sometimes it's tough for me to get a word in edgewise.
mhm,
I have to reel them back in a little bit. But then I get others that they don't want to be here and they don't want to talk. And so I might start with more closed ended with those folks. And
mhm,
I'll describe the symptoms. Like, so I've had people ask me, well, what is anxiety? What is that? I might explain some of the physiological stuff. Like, it could be like your heart racing, deep
mhm,
breathing, sweating. And then if they have trouble understanding the context, I'm like, this might happen in a crowd of people. How are you around crowds at Disney World? And then when I say, then like, okay, that is the anxiety that we're talking about here. One question like that will help me go on into other questions. But I'd say as a whole, I use more of a closed ended, like, are you experiencing any anxiety, heart racing, chest
mhm,
tightness? Or are you having problems with motivation? Maybe you used to like to garden, paint, have wine with the girls. Now you just don't feel like doing that stuff,
mhm.
and they'll be like, oh, no, I haven't done that. And I'm not hanging out with it. I don't even leave my house. Those, that's kind of the style that I use. I mean, everybody's got a different one though.
Absolutely. What about suicidal ideation? I have a lot of veterans who they'll tell me, oh, yeah, I think about, fantasize about ending my life or how things would be easier for my family if I was in here. I'm like, oh, well, did you tell the examiner? Oh, absolutely not. They're so afraid that they're going to get hospitalized. So, do you ask about suicidal ideation and can you kind of differentiate between passive and active and when a situation would lead to hospitalization and that most situations don't?
Yeah, I definitely experienced the veteran trepidation of talking about this stuff. I've had people say, well, that's a loaded question, or I've had people say, can I not answer that question? And
Mm,
and usually that's kind of where I take over, and I'll just kind of break it down like, listen, I understand. I'm not trying to make life harder for you just because you might have a thought about what it would be like if I wasn't here. And
mhm,
I try to explain to that there's a big difference between what would it be like if I didn't have to deal with all of this versus I actively want to do something. And honestly, for me personally, you really have to be committed to it. I mean, it has to be like I have a firearm in the house. I'm going home. I'm doing this. Okay, then that at that point I would breach the confidentiality, but it would have to feel imminent. And most of the times it's not. Most of these folks don't really want to do it. If they do, they're in a lot of pain. But if I start to feel like we're even in a could go either way, then I start asking, what do you do when things start to go down that road? How do you reel yourself back in? And a lot of them will say, it's my kids or it's my wife. I don't know what I'd do without her. Without her, I might actually do something. I do go down the road of plan. If you thought how you would do it, and most people would say, well, no, not like that. I mean, it's more of like, I'm tired of putting up with this kind of a thing. So I do see the passive thoughts about death versus the person where if one more thing goes wrong, that's it. Those are the people I kind of go through it a little more with. But yeah, I definitely ask every single veteran that question as it is part of the DBQ and part of the interview. But I also respect their being the claimant and maybe not wanting to go down that road of admitting it to me. I mean, they don't have to, and I've had people say that, do I have to answer that question? I'm like, no, I mean, you don't have to. But, and even just doing that, then they'll feel more comfortable, because, if I was here saying like, yes, you have to tell me, I mean, of course they're going to be like, well, then no, so I think it's more about getting the information and letting them know that I'm not going to use this information to hurt you. That's not what this is about, but I do feel like I mentioned before that a lot of providers, I do feel like, have itchy Baker Act fingers. And the second somebody even thinks they're going down that road, that they want to get intervention from a third party. And I tell you, that is really just poor training. I mean, because I'm sure you see a lot of people that you're like, this person's they're having a lot of bad days, but they're not going to end the world,
Mhm.
not yet anyway.
And I think it's important for people to understand that I have attorney client privilege. They're going to tell me things because, I can't reveal it. But you also have that as well. You have the doctor patient privilege. And basically, you're going to breach that if you're going to reveal the information that you feel like someone is going to hurt themselves. That's a big deal for you.
Yeah,
That confidentiality is a huge deal for you. And you're only going to reveal that information if it's imminent and you really feel like that danger is there. So it's
yes,
not just, oh, I'm going to hospitalize this person left and right. That's a big deal for you too, because that has to do with your license and your
absolutely.
practice.
Yeah, you'd have to be extreme in I don't know, 6, 7,000 of these exams. I've never Baker acted one of them. There's been a couple that were on the fence,
Mhm.
but I still felt like when they left, they had somewhere to go to. Somebody was caring about them. They weren't just going out into the middle of a field or something like that.
So, how often are you getting veterans with multiple mental health conditions, and how do you handle that?
That's pretty frequent. Usually, especially if it's post traumatic stress, there's usually something else.
Mhm.
Either sleep issues or depression is a big one. And post traumatic stress and major depression almost go hand in hand, depending on where the person is with the PTSD. But that, I'd say, is almost 75, 80% of the time where there's two diagnoses.
So in the DBQ, it asks the examiner if it's possible to differentiate between the symptoms attributable to each diagnosis, like PTSD and major depressive disorder. Sometimes I'll see them differentiate it, but most of the times I'll see examiners won't because they'll say that they can't answer that without speculation. What are your thoughts on that?
It really does depend on the diagnoses. Like if one diagnosis is PTSD and the other one is alcohol use, everything to do with alcohol use is related to alcohol use disorder.
Mhm.
And then every other symptom is related to PTSD. But sometimes there is overlap. For example, you could have post traumatic stress and obsessive compulsive disorder. And then there is a lot of overlap with that, especially with the checking locks and windows over and over again. Part of that is hypervigilance, part of it is obsessive compulsive. It starts to get like, so I do see where there are cases where it can be teased out, but I do run into those where there's so much overlap, it becomes difficult to tease those out. I try to as best I can, or if there's certain ones I know, because the truth is, post traumatic stress looks like everything. Post traumatic stress can look like bipolar with the mood swings. It can look like even schizophrenia with people seeing things or hearing things that aren't there.
Mhm.
Because a veteran that's really hyper vigilant, especially some of those older Vietnam guys, they are so head on a swivel. Their mind starts to produce sounds and images of stuff that's not even there, almost as a dress rehearsal. Like, what would you do if there was somebody standing there?
Mhm.
And so then it starts to look like something else. And that's where if they start to overlap and get that much enmeshed, then I might say something like, other than these symptoms, it becomes difficult to determine which symptoms are attributable to each diagnosis. Or with level of impairment. That
Mhm.
can be tough too. Like if they're diagnosed with depression and PTSD, due to overlapping impairment, it's difficult, the same kind of thing.
Sometimes I'll see though that an examiner says that I think there are certain symptoms that are more attributable to PTSD. And I don't know if it's just that they don't meet the full criteria. Like someone who has depression isn't necessarily going to have flashbacks and
True.
nightmares and hypervigilance and things like that. Are there specific symptoms that are more going to give you a red flag that, oh, this is more leaning towards PTSD rather than major depressive disorder?
Yes. So, and I mean, the truth is, you could have depression and not have major depression as well.
Mm,
Uh,
mhm.
Now, the nightmares and flashbacks are what I like to call the sexy PTSD symptoms. Those are mainstream. They make the
Hmm.
Hollywood. People like that stuff.
Hmm.
But usually I can tell with a couple symptoms. And especially if this is a person who had a normal life. Okay, like we just went through all this background. You didn't have any problems. You were a quarterback of your football team, had girlfriends. You were just a solid citizen. You did community service work. Now, it's anger is a big one. Okay. If you've been
Mm-hmm.
married, most of the Vietnam guys I worked with have been married 3+ times. The most I ever heard was 15 times. And there's a lot of
Wow.
sevens and eights in there too. So if you having this anger that's just pushing people away that was never there, that's showing me the body's going into fight or flight response on the drop of a hat. That's usually my first clue. Like, okay, this has a PTSD flavor to it. Then
Hmm.
the next one is the memory, short term, day to day, just conversations, people's names. We just talked about this. What did I even come into this room to get? So you might see some of these veterans that are so scattered. They have like a pad with them. They got to write everything down, and so that's another big one where I start to go down the road of post traumatic stress, where someone who's truly depressed isn't, let's say, depression without the PTSD stuff usually doesn't have that anger and that
Hmm.
explosive rage that you tend to see with PTSD by itself. There was no PTSD. Somebody with depression would not have that.
Mainstream, you're saying PTSD is the big one that a lot of veterans claim. So, a lot of times I feel like veterans will feel like something is going on, something's wrong. So, they're like, oh, I'm going to claim PTSD. So, when you're ordered an examination, there's a separate examination for PTSD, and then there's a separate DBQ for any other mental disorder. So let's say you have a veteran who comes in, he clearly doesn't have PTSD, he has major depressive disorder. Are you able to then switch over to that other DBQ, or are you limited to saying, well, he doesn't have PTSD? Because technically, on the VA side, they're supposed to maximize the veteran's benefits, and they don't have to properly diagnose themselves. They're just claiming, they're supposed to look at it as they're claiming for a mental disorder. What's your scope on that?
So when a claim comes in, and usually it goes the other way around. Usually the veteran comes in with the DBQ is primed for something like adjustment disorder.
Hmm.
And then I'll go through the records and it's just like, oh, it says here you got a Purple Heart, and you rescued 3 people who were dying. And it's like, this sounds like a little more than adjustment. So then I start going in to the PTSD stuff, and yes, there's a tab there where I can bring any DBQ in, whatever that I feel is pertinent. I mean, there's even a separate one for eating disorders, which is
Hmm.
extremely uncommon, but it does happen. Yes, if I feel or the evidence starts to present itself that we need to go in another way, or this is looking like something else, that DBQ is there. But then they would want me to fill out both. They would want me to fill out the one they gave me and the new one. And I mean, a lot of that is just copying and pasting.
Hmm.
But in the original one, I'll say something in the comments section that says to kind of, something, that prefaces that we need to use another DBQ and this is looking more like PTSD than just adjustment disorder or something like that. But yeah, the provider can definitely alter the DBQ at the beginning and even in the middle of the exam.
So, what are the most common diagnoses that you see?
Well, a lot of those we've been talking about. PTSD is a big one. Major depression is a big one. Somatic symptom disorder, which is primarily anxiety related to medical conditions, which is a big one. A lot of these guys have a lot of medical and physical ailments that now they're not able to do things they were once doing. So, I tell those guys, I'm like, listen, if I couldn't play golf once a week, I'd be a much more meaner person, So, those are the main diagnoses. I say depression, PTSD, anxiety. It could be generalized anxiety, OCD, or somatic symptom disorder. Every once in a while, we'll get bipolar, schizophrenia, once in a while. But I'd say that those others I mentioned that were the main ones.
So, personality disorders are not compensable. How often are you seeing or diagnosing personality disorders?
Extremely rare on that. There's only two I really get, and that's because I was looking at that, and it's interesting. The two I will get are usually borderline personality and antisocial personality, and those two are usually shaped way before the service. Borderline goes back to the Freudian stuff, attachment with primary caregivers, daddy wasn't there kind of a thing. So there's this splitting with relationships. I do see that, but that usually will go back to my parents got divorced. I was in and out of homes. The stepdad used to beat mom, kind of a thing. So that's where I'll see the borderline stuff. The antisocial stuff, people are usually criminals long before they got into the military. So, antisocial people are going to tend to take higher risks. And I usually see that was that person their whole life. It's extremely rare that I diagnose a personality disorder. Gosh, I mean, maybe only a handful of times.
So let's say you did have someone with a personality disorder and then they served in Iraq and were exposed to combat. Could the personality disorder be aggravated by?
Absolutely.
Okay. And could
Yeah.
he have a separate diagnosis of PTSD as well because of that situation that's separate from the personality disorder?
Let's say the person was borderline, but it wasn't enough to pop in on their entrance exam. They might have had some quirky anxiety growing up. I get some people, they might go see a therapist one time. Mom and dad got divorced. They wanted me to talk to somebody. I wouldn't exactly call that therapy. But now this person has resolved all that. Okay. And now they're in the service and they're on a convoy. It hits an IED. Everybody gets killed but them. And now all of a sudden, some of that borderline detachment and splitting from others becomes more, like you say, aggravated. Yeah, I definitely see that. And I would comment on that, though, as well, to say that this might have existed prior to service, but then these service events exacerbated things. Or to give you another good one on that is a lot of folks, like with bipolar, it's usually genetic, but that doesn't mean, like, let's say I have parents who are bipolar. It doesn't mean I'm going to be bipolar, but it also doesn't mean that it's not in me genetically. And a stressor in the environment of like a diathesis stress model, it's like you had one toe in the bipolar pool and the stress of the service kind of pushed you all the way in to where now you're having manic episodes. So I 100% think that any diagnosis or mental health condition that existed prior to the service could be exacerbated by a service event.
So how often are you conducting C&P exams?
Oh gosh, I did 6 of them today.
Wow.
I usually do like 6 to 8 a day, but the most I've ever done is 13. That's back when I was young and crazy. No, I'll do about 6 to 8 a day, 5 days a week. The average psychologist, at least is what I'm told, will do about 3 or 4 of these a day. But this is all I do, so I take on a few more. Plus, I like working with the veterans. They're very real people. But
Yes.
that's my caseload.
So on my side, I see the importance of the compensation and pension examination because that's where you're getting the diagnosis, that's where you're getting the symptoms, that's where you're getting the occupational and social impairment. I mean, I would think that you feel the same way as well, as that the person making the decision on whether they should receive benefits or not, they're really focusing on your exam. That's the meat of the evidence.
Yes.
So, what happens when a veteran misses their exam? Because I always tell them, I don't care if you don't want to go, you have to go because most likely they're going to deny your claim if you don't attend that exam.
It is important to show, I tell folks, you don't want to give anyone a reason to say no. The truth of the matter is the rescheduling of these appointments happens pretty quick. They usually turn it around about a week.
That's
If a veteran calls and says, "Hey, I can't make it today, boss called me in. Is there any way you could get me in on another day?" It has to be done within 48 hours. That's what I'll tell them. It's like, by the time I see your face, I have to turn that exam. But 48 hours from your initial scheduled time. So let's say it was 12 o'clock today. By 12 o'clock Friday, that report needs to be in. So if I could see that person a day later, I will. I try to do anything I can to spare them the agony of having to either come back. Because sometimes I'll get people to show up late. If you show up late, I can't work you in that day. Then we have to reschedule. But they've gotten a lot quicker at turning those around. But here's the bottom line. You do not want to miss twice. If you miss 2 times in a row, they cut the claim. I tell people, unless it's your own funeral, try to be there.
Exactly. And I mean, a lot of people, when they go to the doctor's office, they're like, man, what's taking so long? They're not sitting around doing nothing. I mean, you just said you do 6 to 8 to 13 a day. You're going from appointment to appointment to appointment. And it's important to be on time because that's setting you back. And if they're late, you're moving on to the next appointment. So that's a really important to reiterate as well.
And it's true. And some people, right? I mean, the time is so variable with these folks. I mean, some people that I feel like are about to pop, I try to get them in and out as quick as possible. There's other people that haven't talked about this stuff maybe ever, and then they have a breakdown. I can't just put them. Well, time's up. I got another person. So you have to have that time to kind of let them gather their thoughts and collect themselves before moving on. Like you say, I'm in total agreement. If they can make it, the truth of the matter is, I try to never make anybody wait more than 15, 20 minutes. Most of the veterans do show early for their appointments. It's rare that somebody's on time or late. They're usually early.
So I get to see the full picture. I get to see before the exam. I get to see after the exam. I get to see whether they're service connected or not. Do you only just to get that one point where you do the exam and then it's the next person?
Yes, what I like to call a one and done. Every once in a while, I'll get people coming back on the reevaluation. They can actually request me. I've had several people say, I want him doing it. I'm not doing it if it's not him doing it. And I didn't know that they could do that, but they can. They can request to have the person that did it last time do it again. Yeah, I do find that to be the case.
So besides being on time and being honest, do you have any other tips for veterans when they go to a C&P exam?
Here's an interesting one. A lot of providers will not allow others to come with them, where I feel like I get a lot of information from significant others or family members. The truth is, anybody who's with the veteran there cares about that person, and they're seeing things differently to where the veteran might not admit it. So, especially in doing one with me, I do encourage folks to bring others with them that are seeing them on a day-to-day basis. Another thing is to write down anything specific that you would want to tell me, because a lot of people get in there and it just goes complete mind blank. Like, gosh, there was something I want to tell you. And so a lot of times I'll give them my card and say, you can shoot me an email, I can get things in that way. But other than that, getting on time is probably the biggest one.
Any other final words of encouragement for veterans going to a C&P exam?
Well, these don't have to be painful. I try to make them as painless as possible. Try to get as much out of them for yourselves. It's okay for veterans to ask questions to the providers too. So I would have those questions ready to go. Other than that, I would say just try to be yourself and don't let the anxiety get to you too much.
And don't let the anxiety not make you go. Go to your exams. Trust me.
Absolutely.
Go to your exams.
Well, I always tell the veterans, like, I know you probably didn't want to come here today. This is the last thing you wanted to do, but I'm hoping the juice is worth a squeeze.
Well, thank you so much, Dr. Vonetes. Thank you all so much for watching. If you liked this video with Dr. Vonetes, let us know in the comments. Make sure you leave a like and a subscribe so you don't miss our next videos with him, because this is the first, but it won't be the last. And that leads us to you, Dr. Vonetes. Your focus is veterans. How can they find you and get help from you?
Yes, please reach out to us at docvforvets.com. You can also find the practice at voncare.com, VON care, inc.com.
Well, this was very informative and wonderful conversation. I thank you, and thank you all, and have a wonderful day.
Thanks so much for having me.